Everyone, welcome. Good morning, good afternoon, good evening to wherever you might be. We're very excited to see so many familiar faces on this webinar. I'm going to turn over to Dr. Milind to introduce his extraordinary panel and go through the run of the show for the webinar.
Thank you, Tracy. So I'm Dr. Milind. I am working as a Vice Chair for the WFPICCS Education Committee along with Tracy. Tracy is the Chair for the Education Committee. And this webinar we have been running since past couple of years as a team from the WFPICCS Education Committee. And the purpose of this webinar is to have shared learning from the different parts of the world and what colleagues in the different parts of the world are doing, how are they managing the cases. So it's today the topic is management of pARDS, pediatric ARDS, the case-based learning from different parts of the world. So we have team from Brazil and another team from India. So I'm glad to introduce both the teams and our expert speaker for subjects expert today, Dr. Robinder Kemani. So I'll start with Dr. Andrea, who's the faculty from Brazil. And, Dr. Andrea, if you don't mind, could you please briefly tell about yourself?
Hello, everyone. I'm a pediatric physician at the University Hospital of the University of São Paulo, and I'd like to sincerely thank the World Federation of Pediatric and Home Care for this unique opportunity.
Thank you. Welcome, Dr. Andrea. We have Dr. Luisa, who is the presenter from Brazil today. Dr. Luisa.
Hello, everyone. I'm Luisa. I'm a fellow resident in intensive care medicine here in São Paulo. Can we start the presentation?
Okay.
So we are presenting a PARDS case report today and the evolution of managing a secondary care level hospital in a middle income country. So we are already presented ourselves today. Our center, oh, my dot is out of place. Our center is in São Paulo, Brazil, and that's our hospital. So the case passed in May of 2022 in autumn, and there is a patient of 9 months old, a weight of 7.8 kg.
Welcome everyone, those who have joined late. Dr. Luisa and Dr. Andrea from Brazil are presenting the first case of ARDS managed by them. And we have the second team from India who would be presenting the case after Luisa. And then I shall introduce the second team once the first case is done. Please go ahead, Luisa.
Okay, thank you. So we are presenting PARDS case reports today. We are Dr. Luisa and Dr. Andrea, and our center is placed in São Paulo, Brazil. So the patient is 9 months old, male, weight of 7.8 kilos. 3 days prior to hospital admission, patient started with fever, cough, and nasal discharge. 1 day prior to hospital admission, patient started with a minor respiratory distress. And at admission day, patient present with worsening of respiratory discomfort. A quick initial assessment was provided from the first evaluation, and the altered clinical findings were dyspnea with subdiaphragmatic correction with 58 breaths per minute, and abnormal lung auscultation with bilateral crackles and diffuse wheezing, and hypoxemia with an SpO2 of 86% at room max. So the patient past medical history, the relevant past medical history is a trisomy of 21, Down syndrome, with the other past history with no issues. And the initial diagnosis was an acute viral bronchiolitis and a respiratory distress. So the initial management of the patient was oxygen was given via reservoir mask, nasal irrigation and saline inhalation was performed, and patient showed a clinical improvement. Here we use a score for respiratory distress in bronchiolitis, which indicated a grade of 6, that is a mild respiratory distress. Patient was placed in an observation bed, 0.7 liters per minute nasal cannula, and a viral respiratory panel was ordered. And the viral respiratory panel showed a respiratory syncytial virus and adenovirus also was positive. The patient progression was that patient experienced excessive clinical deterioration. ICU was indicated, but no beds were available, so patient remained at the emergency department. The Brosjot score was 9 at this point, so he had a moderate respiratory distress. An X-ray was requested, and patient was transitioned to high-flow nasal cannula, 2 liters per kilo, with an FiO2 of 40% to maintain oxygenation above 90%. Our ratios on bilateral capacities made a small atelectasia.
So, Luisa, is it possible to diagnose this patient with PARDS at this moment?
So, at this moment, our has criteria for age, timing, etiological, and imaging for PARDS. But the patient is managed now in a high flow nasal cannula, so we can't fill the full oxygenation criteria. So we can classify our patient now as a possible PARDS at this point because he's not being ventilated in the full face non-invasive ventilation with a PEEP above 5 or in mechanic ventilation invasive. Patient was stable at first after the high flow nasal cannula was indicated, but he experienced progressive deterioration and he was escalated to nasal CPAP with a PEPOPS and
what is the importance of thinking about possible PARDS early in this context?
So, by the early identification of patients with PARDS, it's possible to utilize our resources and monitoring in a more targeted and intensive manner, knowing that the patients with PARDS are at a higher risk of unfavorable clinical progression. This is especially important in our country where we have to keep our resources directed to the right patients. So the evolution of this patient was still in emergency department for the first 5 days after hospital admission. He presented with persistent fever, worsening of laboratory and radiographic findings. Secondary pneumonia was diagnosed and some was initiated. He had transitioned ventilation to a non-invasive ventilation with a PEEP of 8, chest support of 10, and FiO2 of 50%. In a full face mask, and he FiO2 release index was of 230. So now he can fulfill the criteria for mild moderate PARDS in a non-invasive ventilation. He was kept sedated, imagine ambulorazepam for the first day.
What do you think is the role of high flow nasal cannula and non-invasive ventilation in PARDS?
So the role of high flow nasal cannula and non-invasive ventilation gains prominence in resource-limited countries. As we know, the high flow nasal cannula effectiveness rises from the reduction of respiratory work and the improvement of oxygenation through the washout of space in the upper airway, as well as enhancement of the inspiratory airflow. So its advantages are a better tolerance with reduced sedation in patients, and it has a possibility of use outside ICU when it is necessary. The non-invasive ventilation, this non-invasive ventilation for design can be used for a trial for 0 to 6 hours. So we can see if a patient with mild to moderate PARDS responds to a non-invasive ventilation. And in that way, we are attempting to avoid an intubation. But it's important to know that patients with a severe PARDS diagnosis has a higher mortality rates in non-invasive ventilation. So intubation should not be delayed in those patients with a non-invasive ventilation trial. So after an initial improvement in non-invasive ventilation, the patient deteriorated once again, developed a severe respiratory distress with paradoxical breathing and somnolence. So orotracheal intubation and mechanic ventilation were indicated by day 4 and started with an controlled mode of ventilation with PEEP of 6, pressure controlled of 16, FiO2 of 35%, and volume 6 milliliters per kilo, and mean body pressure of 14, saturation of 93, with an oxygen saturation index of 5.2 at this moment, again on mild to moderate PARDS at this point. By day 5, patients showed us a fluid accumulation signs with low urinary output. Furosemide was started and patient was transferred and admitted in the intensive care unit. So the ICU management and evolution at patient's admission and the intensive care unit, he had a diagnosis of viral bronchiolitis, community-acquired pneumonia, mild to moderate, and fluid accumulation. He started at first, patient showed us a clinical improvement. We attempted to do a ventilator weaning off, but patient it didn't pass through the attempt. And by day 12, patient was diagnosed with an ventilator-acquired pneumonia and restarted by day 11 actually. It restarted the worsening process. The X-ray of the 12th day was a lot worse with an increased bilateral capacity. So the ICU management and evolution required higher increased ventilatory settings to maintain CO2 above 88%. Here, the C mode was with high parameters, and a strategy was made here to try to improve patients' oxygenation. So ECMO is unavailable at our institution, so we started prone positioning nitric oxide because this patient had a previous history of pulmonary hypertension. We started continued group round, but the patient was still unresponsive to those measures. We did an static pulmonary mechanics with a compliance of 7.5 and resistance also higher of 52 because the primary analysis is bronchiolitis. The peak pressure was 32, the plateau pressure of 23, and the driving pressure of 9 by this time.
Were the ventilatory parameters consistent with the protective ventilation strategy for severe PARDS at this moment?
So, although this patient required a very high FiO2 to maintain oxygenation the first moment, when we see the targets of protective ventilation, the patient is being ventilation in a protective strategy. So the patient was kept in target saturation of 88%. The pH was, we allowed a permissive hypercapnia to avoid higher pressures and volumes. Patient was ventilated with 6 milliliters per kilo, and the pressure plateau was at 23 centimeters of water. The dry pressure was 9 and PEEP was 18, so it was at the FiO2 table parameter for 2 of 9. But although protective ventilation was being despite the higher FiO2, patient couldn't keep and not include oxygenation, so he failed the regular ventilation. High frequency oscillatory ventilation was started by day 12. Patient experienced dynamic worsening after the beginning of the high frequency oscillatory ventilation, and we started vasoactive drugs. We kept the combined strategy of high frequency ventilation with prone positioning. Since patient didn't respond to nitric oxide, we shut it down.
What do you think is the role of prone positioning in PARDS?
So the prone positioning, we have a lack of evidence by now to endorse prone positioning, but it can be considered at our context. For an example, when we have a refractory hypoxemia without other resources available. So if implemented, we have to monitor if the oxygenation is improved or not to maintain the therapy. So the patient's evolution was he had an improvement in oxygenation index in the next few days, and prone positioning was suspended 6 days in 6 days. So we did 18 hours of prone positioning and 6 hours if not for 6 days. Patient by the day 18 of hospital admission showed hemodynamic improvement, sedation decrease, and patient was successfully extubated to a single nasal catheter of oxygen by day 23 of the hospital admission. He stayed with us at the ICU for 21 days, but I thought it was important to mention the patient's disclosure afterwards. He was discharged with 1 liter per minute dependency in oxygen and nasal catheter, and this patient passed away 1 year after this episode from another respiratory failure. He couldn't make to the ICU in the first hours of admission to the emergency department. He passed away. He was diagnosed of pneumonia. So that's our presentation. Thank you, and I'm sorry about the technical issues with the presentation.
Thank
No
you.
problem.
Thank you for the opportunity.
Thank you. Thank you, Dr. Luisa and Dr. Andrea. So we have the second team presenting their case from India. I would like to take a moment to introduce our panelists. We have Dr. Farhan Sheikh, who is the head of the Pediatric Intensive Care Unit at Rainbow Children's Hospital, Banjara Hills, Hyderabad. He is a well-known teacher of pediatric critical care medicine in India and around, and he has numerous publications in peer-reviewed index journals, and he has been the member of technical committee of the National Accreditation Board of Hospitals in India for 4 years, and he is presently the joint secretary of the Indian Academy of Pediatrics Pediatric Intensive Care Chapter. and his special interest and areas of interest are ventilator-induced lung injury, mechanical power, extracorporeal therapies in pediatric critical care, and patient safety and quality. Welcome, Dr. Farhan sir, and he's also been my teacher. And we have Dr. Suchit Jogu, who's a DRNB Pediatric Critical Care Fellow at Rainbow Children's Hospital, Banjara Hills, Hyderabad. He's doing the 3-year specialist course in pediatric critical care medicine from the same hospital. So over to you, Suchit.
Yeah. Good evening, everyone. Can you see my slides?
Yeah.
Okay. The slideshow mode, is it on?
Yes.
Okay. Thank you. Good evening, everyone. It's a great feeling for me to present a case scenario on this platform. People from different parts of the world have joined. I would like to express my sincere thanks to the organizers for giving me an opportunity. So I would like to dedicate this presentation to cherishing legend Professor Luciano Gattino. Myself, Dr. Suchit, I'm a PSU fellow from Rainbow Children's Hospital, doing fellowship under the guidance of Dr. Farhan Sheikh. So coming to the next child, we have 14-month-old resident of Ghana, who was previously well child, presented with 7 days history of moderate grade intermittent fever and cough for the past 7 days and multiple episodes of loose stools 1 day before admission, for which he was admitted in nearby hospital and then he was referred to Rainbow for further treatment. At admission, child was having severe respiratory distress with subcostal and intercostal retractions and was hypoxic. And child also had compensated shock with poor peripheral pulses. Child was drowsy, who was arousable only to painful stimulus, and was also having severe mottling on exposure, requiring level 1 immediate resuscitation. Initial blood gas showed metabolic and respiratory acidosis with hyperlactatemia and hypoxemia with low SF ratios. And because of severe respiratory failure, hypoxia and lethargy, child was intubated immediately under the cover of adrenal infusion. And also child received 10 ml per kilo crystalloid bolus and later started on inotropes. This was the first chest X-ray of the child showing bilateral diffuse opacity. In the index child, the non-invasive ventilation was not tried because, as we can see, the child was already in compensated shock and was also drowsy. So there is no point of trying non-invasive ventilation in the index child. After intubation, the child was started on mechanical ventilation with pressure control mode with a PEEP of 10, PIP of 26, plateau pressures of 26, and driving pressures of 16 with 100% FiO2 generating tidal volumes of 6 ml per kilo. And ABG showed worsening respiratory acidosis and metabolic acidosis, and although lactates have improved a little bit. And alveolar dispatch fraction was 38% initially. At this point of time, if we see and calculate the mechanical power by Becker's equation, the mechanical power would be 6.77 joules per minute. Initial PF were low and oxygen index was very high. So as our colleagues from the Brazil has already described, the lung protective ventilation strategies as per PALIC2 guidelines have been followed in the index child with tidal volumes of 6 to 8 ml per kilo, maintaining plateau pressures less than 28 centimeters of water, with limiting the driving pressures to 15 centimeters of water, and PEEP titrated according to best oxygen delivery and hemodynamics. Initial 2D echo showed features of RV dysfunction and mild tricuspid regurgitation.
My mic is switched off. How do you select the PEEP while ventilating a child with PARDS?
So if we see PALIC recommendations, PEEP selected at or above low PEEP FiO2 table has been recommended, and it has moderate certainty level of evidence as per PALIC2. And this is the low PEEP FiO2 table which the ARDS network group people has recommended. But if we see the PEEP recommendations according to the group are quite high as per this table. Indeed, over the last 4 years, the studies published in various international journals like Respiratory Care, Pediatric Critical Care Medicine, and Critical Care showed the median PEEP in pediatric age group is only 6 to 7 centimeters of water. And higher PEEP may improve oxygenation without actual alveolar recruitment by reducing right ventricular output so that less blood passes through the shunt areas and thus a reduction in venous admixture, and also by operating Henry's law. Moreover, PALIC2 suggests that when adjusting PEEP levels to achieve proposed oxygenation targets for pARDS, attention is to avoiding the exceeding plateau pressure and driving pressure limits. Although no single best method of PEEP titration has been established, an optimum PEEP is where there is improvement in compliance, better carbon dioxide clearance, and improved oxygenation. So if we see in the index patient, we have titrated PEEP, noting down the values of plateau pressure, compliance, driving pressure, hemodynamics, oxygenation saturations, and carbon dioxide clearance. There are few other techniques of PEEP titration like stress index, although it is not validated in children, esophageal pressure based PEEP titration, CT guided PEEP titration, ultrasound guided PEEP titration, electrical impedance tomography, etc.
Suchit, can we use driving pressure as a tool for PEEP titration?
Yeah. So driving pressure It's a tidal volume adjusted for available respiratory compliance. Hence, it is a better tool for titrating tidal volume for available respiratory compliance. In volume control mode, the change in driving pressure gives us idea of available respiratory compliance and tidal volume.
What does PALIC2 say regarding recruitment menu, Dr. Suchi?
Although PALIC2 does not give any recommendation per se for recruitment maneuvers, but however, careful recruitment maneuvers may be applied to improve oxygenation by slow incremental and decremental PEEP steps. Sustained inflation maneuvers are, however, not recommended.
So, how do you use the concepts of driving pressure and mechanical power in management of PARDS?
So, coming to the concept of driving pressure, it's a tool to titrate tidal volume for the available respiratory compliance instead of body weight. In the adult age group, as Amato has already described in 2015, that a driving pressure of more than 15 centimeters of water has been associated with poor outcomes. In children, the concept of driving pressure is still not validated. In most of the children, are ventilated with pressure control modes of ventilation, and hence driving pressure PIP remains fixed and driving pressure remains fixed. So the concept of driving pressure took some time to establish in pediatric critical care. However, Van Shelvan in his pediatric study found the driving pressure to be less than 12 in normal lungs while less than 14 per ARDS as a safe threshold. And PALIC2 also suggests limiting driving pressures to 15 centimeters of water for patients with ARDS. Coming to mechanical power, in 2016, Dr. Luciano Gattinoni and his team suggested an equation of mechanical power for volume control mode. Later, various equations have been described for various other modes also. So basically, mechanical energy is calculated by modified equation of motion depicting the energy contribution of various pressure and non-pressure parameters and multiplying it with respiratory rate and finally expressing as joules per minute. Here we can see the equation of mechanical power. So coming back to the index child, here if you remember, at the PEEP of 10, driving pressure of 16, and we have the mechanical power calculated as per Baker's equation as 6.77 joules per minute. And later we have done PEEP titration in the index child, limiting the driving pressures with low driving pressures, the best compliance, best hemodynamics, best saturations, and best carbon dioxide clearance. So before PEEP titration, if you can see, our plateau pressures were 26, driving pressures were 16, and alveolar dead space fraction was 38%. And after titrating the PEEP to 12, as lungs are recruitable, the PEEP plat came down to 24, driving pressures came down to 12, oxygenation has improved, and alveolar dead space fractions has also improved. But mechanical power is remained the same, that is 6.7, it is still high. So if we see the pictorial representation of various components of mechanical power and their contribution to the mechanical power, the tidal volume, flow, and driving pressure, the leftmost line, the tidal volume, flow, and driving pressure, they contribute a lot to the mechanical power equation, followed by respiratory rate and least by the PEEP. So till now we have only titrated the PEEP, the index child, and we have made the PEEP to 12. And we were ventilating at a tidal volume of 6 ml per kilo and rates of 40 per minute. After reducing the tidal volume to 4 ml per kilo and reducing the respiratory rate to 30 per minute, we can see there is a significant reduction in mechanical power to 3 joules per minute. So high mechanical power could have different interpretations. So there could be severe underlying disease and adequate ventilation settings, or there are severe underlying disease with injurious ventilation settings, or simply they can be just injurious ventilation settings. In adults, mechanical power of more than 12 to 13 joules per minute has been associated with poor outcomes. But however, in children, respiratory rate decreases and tidal volume increases as age increases physiologically. Hence, in children, there is a need to normalize mechanical power to either body weight or respiratory compliance. Bhalla et al. In the year 2022 has showed that mechanical power normalized to body weight was associated with fewer 28-day ventilator-free days. This is a study published from our unit by Dr. Farhan in last year to January 2024 showed that when mechanical power was normalized to respiratory compliance, it was more associated with outcomes mainly 28-day ventilator-free days than mechanical power or mechanical power normalized to body weight. So coming back to the index child, 12 hours after admission, the ventilator requirements of the index child has increased, the ventilator pressures have gone up, and the PF further decreased and oxygen index have gone up. And there is worsening respiratory acidosis and metabolic acidosis, and the lactates have increased. So at this point of time, recruitment maneuvers like prone position was thought of, but it was not done in our index child because of severe hemodynamic instability and RV dysfunction. So in view of persistent hypoxemia and worsening ventilation parameters, as a rescue therapy, we have started child on high frequency oscillation along with inhaled nitric oxide therapy with a MAP of 23, with an amplitude of 75 and 100% FiO2 with a frequency of 10. So this was a chest X-ray done on HFOV with a MAP of 23.
How do you set your mean airway pressure on HFOV, Dr. Suchit?
So on HFOV, if we see MAP is set by stepwise increase in MAP method. So mean airway pressure is increased by 2 centimeters of water every 3 to 5 minutes until the onset of lung recruitment happens, and it is identified by increase in saturation, and stepwise increase is continued till there is no further improvement in oxygenation or where there is sudden decrease in the mean arterial blood pressure. That is taken as the peak point, and from there slowly gradually it has decreased in stepwise manner every 3 to 5 minutes, and we have to stop where there is decrease in saturation again. So optimal MAP is set 2 centimeters above the de-recruitment MAP. Okay. So over next 6 hours in the index child, the hypoxemia persisted, there is further worsening of PF ratios, and oxygenation index have worsened. Patient attendants were counseled regarding the need for ECMO at the current situation.
What are the current criteria to start ECMO as per various guidelines, Dr. Suchit?
So if we see the ELSO criteria, these are the common conditions requiring ECMO, and they have given a cutoff of oxygenation index of 40 and PF ratios of 60. Although these are not hard and fast rules to start ECMO, we can still start ECMO even these parameters are not met if the clinical condition is indicated. In adult Eolia trial, for the initiation of ECMO, they do not include oxygenation index at all. As per this trial, patients are initiated on ECMO based on PF ratios only. So in the index child, VA ECMO was initiated and drain cannula was placed in the right IJV and return cannula placed in the right internal carotid artery, and position of cannulas were confirmed by 2D echo and X-ray. Gradually, ECMO was weaned over next 2 weeks, and child ventilation settings was weaned over next 4 weeks, and finally, and this is the index child, we can see there is during the ECMO initiation, we can see the ECMO cannulas here, and gradually the chest X-rays has improved, and child was discharged after 28 days of PICU stay, and this was the X-ray at the time of discharge, and we can see the happy child going home. So this is our center in Hyderabad, India, where we work. Thank you.
That's great. Thank you, Suchit and Dr. Farhan. So I would request all the audience to send their questions if they have any in the chat. We have a Q&A session at the end, wherein our panelists and experts, including Dr. Robinder, will take the questions at the end. So I would like to introduce Dr. Robinder Kemani, who is our subject expert for the topic today for pediatric ARDS. So Professor Robinder Kemani is an attending physician in pediatric intensive care unit at Children's Hospital, Los Angeles, and he is the vice chair of research for the Department of Anesthesiology and Critical Care Medicine, professor of pediatrics and clinical scholar at University of South California. And his research and educational programs focus on respiratory disease in critically ill children, particularly as it relates to mechanical ventilation and acute respiratory distress syndrome. And he has been one of the pioneers and researcher in ARDS, and he has done a lot of work in ARDS, and he would be the best person to speak about ARDS and PALIC-2 guidelines. Welcome, Dr. Robinder.
Thank you so much. That's very kind, unnecessary introduction, but thank you all. Really, those were amazing cases. I was really impressed by those presentations, and I liked how you sort of took us through the beginning to the end of the case for all of those patients and sort of thought about the application of, what PALIC criteria might suggest at various different points. But I think this actually provides a really nice opportunity to discuss limitations, right, that exist with these clinical practice guidelines. And I think that the reality is that when you create clinical practice guidelines, you're doing it based on existing evidence, and you're doing it based on the population overall, right? So on average, when you have patients with this disease or this condition, how should you generally treat them? But the challenge in clinical practice guidelines and translating them back to the bedside is that there's a lot of patient-specific heterogeneity, right? Not every patient is going to respond the same way. And when we look at our pediatric guidelines in particular, what what we struggle with is we don't have a lot of randomized control trials, right? So if you have randomized control trials that say, when tested on a large population of children with ARDS, this is the overall benefit of the treatment and it's very strong in a positive direction, then you can get a strong recommendation, right? But if you look to all of our PALIC recommendations, none of them were strong. All of them were weak, or one with moderate level of evidence, which was the PEEP-FiO2 table. And even that is not based on a randomized controlled trial, right? That's based on several observational studies as we go. So a point that I want to make sure is clear is even within the context of the PALIC recommendations, you have to use your clinical judgment, right? And that you don't apply this blindly for every patient. If the patient is not responding to that particular therapy in that way, then you may need to make an adjustment. And what I will do is I will share a few slides because I think that they speak to this heterogeneity concept. Can you guys see this okay?
Yes, sir.
Yeah. Okay. So as we think about PALIC, PALIC criteria, right? We had our creation of a specific definition, and I think of the first case highlighted some of the complexities with the definition, especially as we think about high flow nasal cannula, for example, and non-invasive ventilation and the differentiation between at risk versus true ARDS. But what I want to spend more time talking about is this idea of heterogeneity of treatment effect and how that might relate to thinking about the treatment strategies that we may think about for these patients that you guys often, went through with this case. And increasingly over time, we've realized that when you have clinical syndromes, especially syndromes like pediatric acute respiratory distress syndrome, within each of those patients, right, that meet that diagnostic criteria that we showed earlier, they may have differential biology and they may have differential treatment response that's happening. And that can be classified as a phenotype or a subphenotype, which you might be able to do from things like the clinical presentation, the physiologic responses, the triggers, things that I think about here with subphenotype. For example, were highlighted in that first case, right? That this was a patient that presented with viral mediated disease, had a clinical phenotype that initially seemed like more lower airway obstruction with bronchiolitis, and then developed a secondary ventilator associated pneumonia and had some evolution, right? That happened in that time. And as we try to get towards more biological treatments, like drug treatments, for example, what might be more important is that we get to the endotype. Right, we get to what the specific biological mechanism is at play with that patient and their ARDS. Do they have a lot of microvascular thrombosis, as an example, where anticoagulation might be an appropriate mechanism or might be an appropriate therapy to think about, for example? Do they have high amounts of inflammation, where anti-inflammatory medications might be the appropriate thing to think about? And I think we're at the cusp of just trying to start to understand these subphenotypes and these endotypes and how that might drive therapy. But ultimately, I'm a physiologist. That's what my real interest is. And so I think that there's a lot that we can learn, and was highlighted, I think, in these cases, even in the subphenotype level, those observable characteristics and physiologic responses that can help us decouple, how we should approach these ARDS patients, even within the construct of the PALIC guidelines. And when we think about that, what I'm alluding to is this idea of heterogeneity and treatment effect. That is, that there's non-random variation in the benefit or harm of treatment for a specific therapy that is attributable to some specific characteristic of the patient. So that might be the trigger for the ARDS, that might be a comorbidity, or that might be the biology, right? Like are they really inflamed or not? And so as we think about that, in pediatric ARDS in particular, right, all of these factors, I think, are important potential sources of heterogeneity and treatment effect, both either for the outcome or how they're going to respond to therapy, the trigger for ARDS, the pathway, the physiologic mechanisms, the comorbidities. And then we have specific issues, in pediatrics that are unique from adults, which is age and respiratory system development and how that might alter as a function of time. And I think the mechanical power discussion was a perfect example of how that might differ as a function of age. The existing literature has focused a lot on biology, right? These idea of subphenotypes of inflammation in particular that have been represented in both adult and pediatric cohorts, and that this inflammatory response in particular might be a source of heterogeneity of treatment effect for PEEP response, for example, in adults, for tight glycemic control response in some of the pediatric data, as an example for septic patients or septic NARDS patients. But what I think is even more important is the heterogeneity and treatment effect that might be seen from these physiologic responses. And this was a comment that came up in the second case, which is this idea of, should we do recruitment maneuvers, right? PALIC is neutral about recruitment maneuvers, but then it says if we are going to do a recruitment maneuver, right, we do it with incremental increases and decreases in PEEP. And what I think is important to remember about the recruitment maneuver, and this forms the basis for why those recommendations were written the way that they were, is that if you're not careful with recruitment maneuvers, you actually might cause harm. This is the ART trial, right? The alveolar recruitment PEEP titration trial in adult patients with ARDS, where they compared the low PEEP FiO2 table to this relatively aggressive recruitment maneuver that they had with PEEP titration, and that group did worse. The group that got the alveolar recruitment and PEEP titration actually had higher mortality. They had more pneumothoraces. And it highlights the point that if you're aggressive with an attempt to recruit lung that is not recruitable, you actually might cause more harm in that process than you would if you took a little bit more conservative approach. And so that highlights the need to be careful when we do recruitment maneuvers as an example. That being said, I very frequently do recruitment maneuvers as part of my normal practice, because just applying a blanket PEEP might not be right. And the second case, I think, highlighted that case, or that the case to do that with a very good example of it. Now, let's talk a little bit about lung protective ventilation and then how to put this sort of together here. When we think about the concepts of lung protective ventilation and the PALIC recommendations specifically in each of these areas, right? First goal, limit strain. And this is classically the sort of volume trauma hypothesis. But it's reframed from this idea that strain is maybe the more important concept to think about. Strain is the change in the size of the lung or the tidal volume relative to its original size, which is the functional residual capacity. So if you've got a patient that has very severe ARDS with lots of loss of lung volume, so significant alveolar consolidation or alveolar collapse where you have a drop in the FRC, then that's the patient that we should be using those even smaller tidal volumes for, because we want to keep the strain on the lung in a safe range. Same concept exists with stress, right? Stress is the transpulmonary pressure variables. In particular, that's the specific variable. Our recommendations are based largely on plateau pressure and driving pressure, because we don't routinely measure the transpulmonary pressure in our clinical practice, right? We don't usually use esophageal catheters as an example. But that's what underscores those ideas of need to limit both the driving pressure and the tidal volume. And the two need to be put together because, of course, they're related to one another, right? The patient with the most reduction in functional residual capacity typically has the biggest loss in lung compliance. That's the one that you need to keep the tidal volume lowest in order to achieve the driving pressure or plateau pressure targets. And then, of course, it's related to preventing adolect trauma, i.e. providing enough recruitment, whether that's with the recruitment maneuver, but more specifically with the use of PEEP. And so let's take this case. And I'd like to use this as an example about how you can adjust or should be thinking about differences, for example, within that tidal volume range, right? We have a large tidal volume range that we say is acceptable for patients with ARDS. So this is a 3-year-old girl, viral pneumonia, AC PRVC mode. The tidal volume is 6 per kilo. PEEP is 10. FiO2 is 50%. Plateau pressure is 22. Triggering each breath on the ventilator and has a reasonably normal arterial blood gas. And this is the flow and airway pressure tracing. So when I look at this, I think we're in a fine shape here, right? This tidal volume is likely adequate for this patient. The patient is spontaneously triggering breaths, at least, and breathing, and there's no clear flow dysynchrony when you look at the flow and the airway pressure tracing. The plateau pressure is in a safe range. The driving pressure is in a safe range. We're hitting our, an acceptable oxygenation and ventilation. I think we're in good shape here, right? In contrast, you take that same or similar patient, right? Actually has the same blood gas, the same ventilator settings, and this is what you see, right? So what's going on here? So this patient has pretty significant flow dysynchrony. Right? As you look at the flow tracing, it's an inadequate support type of dysynchrony. They're trying to pull additional flow, and that results in a second breath for the patient. So the patient has breath stacking that's occurring as a consequence of that from a phenomenon of flow undershoot. Now, the plateau pressure is in a safe range. The driving pressure is in a safe range. So for this patient, right, this tidal volume of 6 mLs per kilo is unlikely adequate for that patient, or the driving pressure that we're providing for that patient is unlikely adequate if I'm going to keep them spontaneously breathing, right? So in this situation, this would be one where we might consider, actually, let's increase the delta pressure for this particular patient, allow them to have a slightly higher tidal volume because I'm in a safer range to prevent, for example, the breath stacking that might be occurring for this patient. Okay, let's move on to the selection of driving pressure or transpulmonary pressure here. So remember, when we think about lung stress, the important concepts are transpulmonary pressure either at the end of inspiration, or the transpulmonary pressure at plateau, or the transpulmonary driving pressure. Now, I keep saying transpulmonary pressure. What's the difference between transpulmonary pressure and airway pressure, right? So airway pressure, if we think about peak pressure as an example, or even pure plateau pressure, is representative of both the lung and the chest wall components. When we think about the true stress on the lung, what we need to think about is the stress across the lung, i.e. the alveolar pressure minus the pleural pressure. So if I've got a patient with a very stiff chest wall, I might be able to use slightly higher driving pressures or slightly higher plateau pressures. Whereas if I've got a patient who does not have a stiff chest wall, in fact, maybe has a very, very compliant chest wall, then the opposite might in fact be true, that I should be even more careful with the inspiratory pressure limits that I'm applying, or the driving pressure limits that I'm applying. It's in fact very difficult to actually estimate this without a direct measure with esophageal pressure. But this is the important concept to remember, that it's not just the airway pressure that's important, it's really the transpulmonary pressure that's important. And so we've talked about these limits as part of the previous other cases. But the point I want to make here is about the plateau pressure, right? So we have historically not measured plateau pressure in pediatric patients. Why? Because we use mostly pressure control modes of ventilation, or pressure regulated volume control, i.e. decelerating modes of ventilation. And there's a common belief that if you have a decelerating flow mode of ventilation, that the plateau pressure is going to be, the same as the peak pressure. And so if we just limit the peak pressure, we should be okay. But in fact, that might not really be true, right? In fact, it is not true. And we do need to measure the plateau pressure even in pressure control decelerating modes of ventilation. And this goes back to the equation of motion of the respiratory system. So remember the equation of motion of the respiratory system, that the pressure that's generated is shared between what we deliver on the ventilator and what the patient is doing. The patient effort is the pMUSC component. And there's elastic components, which is based on the elastance of the lung and the tidal volume that we apply, and resistive components based upon the resistance of the airways and the amount of flow. And then if this is measuring the peak pressure or the total inspiratory pressure, for example, then we add PEEP on that side. The point here is that the patient effort may contribute to this driving pressure. The other important point is that airway resistance and flow also contribute to this total pressure. So if we really want to understand what's happening at the alveoli, we must have static conditions, which means we must have a condition of no flow, right? By doing, for example, an inspiratory hold, to have that resistive component go to zero to measure the plateau pressure. And as we look at the plateau pressure, what we see is that it can be higher, the same, or lower than the peak inspiratory pressure. And in such circumstances where patients have very high amounts of respiratory effort, as an example, the plateau pressure will actually be higher than the peak inspiratory pressure, because the patient is pulling that tidal volume, contributing to that tidal volume pull, right, by generating that inspiratory pressure. And this is stuff we've shown, and of course has been shown in adult patients too. So we should be measuring the plateau pressure in all of our patients if they are passive or they are active, right? And it's not just in volume control modes of ventilation, it's also important in pressure control modes of ventilation. And if you look at this circumstance here on the left, even in a passive patient, the peak pressure does not necessarily estimate the plateau pressure, especially if, as you look at the flow versus time scalar, you don't have an inspiratory pause. So in this example here on the left, if we set our inspiratory time so that flow comes to zero with a very slight inspiratory pause, now the peak and the plateau pressure are close to one another, because you've almost achieved zero flow conditions here. In contrast, when you look here, right, you see that flow has not gone to zero in this flow versus time curve. So not surprisingly, the plateau pressure is considerably lower than the peak pressure. And I was struck by the first case of that patient with bronchiolitis as an example, where there was such a large discrepancy between the peak pressure and the plateau pressure, with the plateau pressure so much lower than the peak pressure. And one of the points that I would say is important to think about is when you set the inspiratory time. I noticed the inspiratory time was quite short, 0.55, that was used in that case. If you don't have this flow that comes to zero, right, then the effective alveolar pressure is likely considerably lower than the peak pressure that's being applied, underscoring either the need to measure the plateau pressure consistently to know if you can increase assistance on the ventilator, or pay close attention to how you set the inspiratory time in a way that ensures that flow comes down to zero and there's a slight pause here so that that pressure in a passive patient more closely represents the plateau pressure. And in an active patient, of course, as I showed before, the plateau pressure may be higher than that peak inspiratory pressure. Okay, I could talk about PEEP titration, but I think I'm going to pause and maybe we can do that as part of the sort of larger discussion. So I'm going to stop here because I think it would be even more relevant to kind of hear what people want to hear about, what questions they may have, and we talk about it in that way.
Thank you, Dr. Ravinder. So it was really very great to hear from the experts. So I would request the audience to send their questions in the chat box if they want to ask anything to our experts. I could see some questions in the chat box. Let's take one by one. So there's one question by Kushbu. She's asking how to make mechanical power applicable easily at bedside. So Dr. Farhan or Dr. Ravinder, if you would like to take this, Dr. Farhan.
Okay. So as Dr. Suchit showed, applying mechanical power in pediatric age group is little tricky because in children age is increasing, respiratory rate is reducing with increasing age, and tidal volume goes on increasing. So Dr. Martin Neighbor in his paper had shown that a better idea will be to calculate mechanical energy rather than mechanical power. So they removed respiratory rate from the equation. But the problem is respiratory rate is the key thing in the whole equation of mechanical power. If you remove that and you have only mechanical energy, then it becomes per breath, just like driving pressure. So it doesn't give you an entire picture. So that's an issue. The second option was to normalize it to body weight or respiratory compliance or height. So we did our study and we found in our retrospective study that normalizing to compliance was a better strategy compared to normalizing to body weight or mechanical energy also. So still we don't know what is the cutoff value for at different ages depending upon normalizing to compliance. There is one ventilator by Mindray company which is automatically calculating mechanical power by an algorithm. It calculates the area under pressure and volume and then multiplies by respiratory rate, and every 30 seconds it refreshes and displays mechanical power on the screen of the ventilator on pressure as well as volume control mode. So in Chimulu et al, they have done one study and they have found that it correlates very well in adults, pressure control as well as volume control mode at different PEEPs and different tidal volumes. We are doing one study in our unit right now, and we have a data of 104 patients till now. And we found that it is correlating with blind Titleman analysis. We found that it is agreeing with all different volumes, only in volume control mode in children. In pressure control mode, somehow, it is not agreeing at various tidal volumes. We don't know the reason. We called the engineers to check for their algorithms. There was a snag in the software. It is correlating only in volume control in children, not in the pressure control in our cohort. We checked in normal lungs as well as ARDS lungs. So we still don't know. But one thing is, as Costa et al. Paper had shown, that mechanical power is just an indicator of either your bad settings or a bad lung or both. So you need to use it like that rather than use it for a prognosis or something. I don't know what Dr. Ravinder sir says.
Yeah, I think you highlighted a lot of really important points about mechanical power that I won't reiterate because I think you hit them well. How to normalize to tidal volume versus compliance. I agree. I think compliance is the most appropriate way to likely do that, and the pediatric specific challenges that we have based upon age and rate. What I would caution us against is using mechanical power as a dogmatic way to say the mechanical power is high, so I need to reduce the ventilator settings or I need to move the patient onto ECMO. I think we do not have any evidence that should tell us to do that. I think like most of the things that we do in intensive care, we use monitoring parameters to understand the trajectory of the patient, right? And a single point of a high power or a high plateau pressure or a high oxygenation index doesn't or shouldn't drive our decisions immediately at that first point. It's a trajectory of change of how the patient responds. So we try an intervention, we see an improvement, right? I think with OI and ECMO is a perfect example of that, right? You don't put a patient on that has a single OI of 40, but you look at the trajectory of the patient over time and you say, oh, this is worsening, right? Okay, I better do something different. And I think mechanical power is an opportunity to look at it in that same way. It's a monitoring parameter that tells us, is the amount of energy that I have to put into this lung increasing over time? And does it improve in response to a therapy that I might try, in response to prone positioning, in response to a recruitment maneuver, in response to manipulation of PEEP? Because if you start to see that improvement, and in fact, if you look at secondary analysis of adult RCTs, Vicente Modesto Alapuente has done this from Spain, looking at the mechanical power response between intervention and control patients in sort of lung recruitment studies, i.e. open lung strategies. The groups where the open lung strategy had a drop in the mechanical power, right, are the ones that had that improvement in outcome. So it probably is a good way for us to tell if the patient is responding or recruiting from the lung protective strategy that we may be trying or the recruitment maneuver strategy that we may be trying. But I don't think we should be dogmatic about a value, and that leads us to either go to ECMO or something else, or even reducing the settings just to get below a mechanical power threshold. I'm not sure that we have enough information about that yet.
Thank you, Dr. Ravinder. So there's one more question. I think most of the new entrants or the new trainees would have this question in their mind. How to titrate the PEEP till you find the optimal PEEP, and how do you do the recruitment maneuver? And they're asking over how many minutes. So if anyone wants to take this, I can see Dr. Farhan smiling. I think he's the best person to tell about this.
I'm not the best person, but there is no method. There is no specific method, and I think it was one of the last editorial by Dr. Luciani was about titration, the gray, the white, and the black, something like that. There was a title about PEEP titration. Very nice editorial, and I could read the frustration in his tone, the way he had written that editorial. So there is a lot of controversy. There are two recent guidelines came, American Thoracic Society guideline and European Society, and he was commenting on that. One guideline is saying that you should use as high as possible PEEP, and another is saying that you should be conservative in titrating PEEP. And both were published back to back in 2023 and 24. So Dr. Luciani Gattinoni sir was talking about how the evidence is so sparse and we still don't know how to actually titrate. So as Dr. Suchit mentioned in his slides, you just need to see whether your lung is recruitable or not, first of all, and how to know that. There are various methods. The simple method is just increase the PEEP from 6 to 8, 8 to 10, and you see whether your blood pressure is coming down, your compliance is improving. If that's happening, and you look at the reason for ARDS also, if it is indirect ARDS, mostly it will be a recruitable lung. And then in that case, you can try recruitment maneuver if needed. Unnecessarily, you don't need to try. Actually, every patient doesn't need. And otherwise, you can do a simple PEEP titration. And whenever a best PEEP means not just improvement of oxygenation, but you would also see improvement in compliance and carbon dioxide elimination. That is very important. Because if you just keep high PEEP, oxygenation may simply improve because your less blood is going through the shunt, because the afterload on the right ventricle is increasing. And there is one Henry's law also. So when you're increasing the mean airway pressure in the mixture of gas, partial pressure of individual gas also increases. So it may be just a spurious increase in the oxygenation. So just improvement in oxygenation should not be the criteria. Compliance also may spuriously improve because some alveoli which are already open may further open, and you may see that compliance is improving. So compliance improvement, oxygenation improvement, along with elimination of carbon dioxide is important, because once carbon dioxide is improving, that means your perfusion to the lung is also good, and hemodynamics also has to be stable. So Dr. Gattinoni sir was emphasizing on importance of looking at hemodynamics, because if your hemodynamics is not good, there is no point in keeping the alveoli open which are not perfused and which are not participating in gas exchange.
Great. Thank you, Dr. Farhan.
If I may add a comment to that, I think that was really elegant, a really elegant description of it. And I think what it highlights too is when the parameters don't agree, right? When oxygenation and compliance and hemodynamics and dead space don't sort of align with one another, right? In a particular patient, what to do, right? And I think that that's a particular challenge that probably needs to come back to what's the highest risk for that patient. So if that patient, I'm struggling to maintain plateau pressure and driving pressure limits, right? I might try to optimize compliance a little bit more because I'm worried about the risks of ventilator-induced lung injury. If that patient, I'm really struggling with hemodynamics, right? And I'm worried about RV interdependence, right? And pulmonary blood flow, et cetera. Then I might optimize or prioritize oxygen delivery or hemodynamics or cardiac output, because that's what's particularly important for that patient. Going back to that original point, that is, you have to have individual patient consideration, based on the patient heterogeneity.
Okay, nice. There's one more question by Dr. Ashwini, who is asking, is there a need of considering ECMO earlier than the trials of FOV, which might reduce the time spent on ECMO and overall hospitalization? Maybe a lower threshold or earlier escalation to ECMO. Dr. Andrea, do you want to? Dr. Andrea? Okay.
Yeah, she's there.
Hi, Dr. Andrea.
The question here.
Sorry. So I'll ask the question again. Is there a need of considering ECMO and which might help reduce the time spent on ECMO and overall hospitalization in children with pARDS who are going on to HFOV?
Sorry, I have no experience with ECMO since we don't have ECMO.
Okay. So Dr. Farhan or Dr. Robinder?
I think I'll say some first and then can. Yeah, so I'm going to come from the perspective of India, resource limited country, and ECMO is extremely costly here and it's not easy. And I have seen some pediatric departments which are part of adult centers in India are starting ECMO very early nowadays because they have a very good availability of cardiothoracic surgeons and it's very easy for them to cannulate and start ECMO. And what I am seeing of late is they are decannulating also within 4 or 5 days. So those children, and that is respiratory ECMO, not cardiac ECMO. So are those really genuine indications for ECMO? That is my question. Are they just starting because they had the availability of starting early? So that is one thing. And then as I was talking about American Thoracic Society's guideline of 2024, they have actually given weak recommendation for ECMO, citing Caesar trial and Eolia trial. And they are saying that increases the cost, increases the incidence of complications, and children can get stuck on ECMO for a long time because the theory that just give rest to the lung and lung will heal, that won't happen every time. And it can lead to complications, bleeding and hemorrhages and all that. My colleague, Dr. Martin Neber, with whom I'm doing 3 researches, he always joke that those who don't know how to ventilate, they do ECMOs. So it all depends. So you have to try your lung protective ventilation. Of course, early ECMO is always better compared to starting very late also, once your fibrosis has set in and you're starting too late. But early doesn't mean that you don't try HFOV or you use HFOV just as a bridge for 12 hours so that you start ECMO early. I think there has to be some balance in between.
I agree. This is a really complicated question that I don't have the correct answer to because I don't think we as a field know what the correct answer is to this. And just to highlight some of the points that you make, okay, so we're a more well-resourced place. I put almost nobody on ECMO for ARDS. Maybe we put 2 or 3 patients a year, and we're a very high volume ARDS center. And what's the difference, right? We all have different thresholds for when we will pull that trigger. And it's not just about the limits on the lung protective ventilation, i.e. what PEEP I'm willing to go to, what driving pressure I'm willing to go to, what plateau pressure I'm willing to go to, but it's the other side too, which is at what level of permissive hypercapnia am I tolerating? At what pH am I tolerating, right? So we have frequently, in these circumstances, when I've got all other organ systems working, I may allow the pH to be 6.9 in a patient, right? Because I don't know that there's enough evidence to suggest that ECMO is better than very, very permissive hypercapnia, as an example, right? And we haven't answered that question, I think, in our field yet. So there are lots of risks potentially with ECMO, especially if you're a low volume ECMO center. So if you're a very high volume ECMO center that does 50 cases of ECMO a year, that might be the best thing to do because in fact, you're maybe better at ECMO than you are at lung protective ventilation. And that's probably the better outcome for that patient. And the flip side, if you're not, right, then get really good at lung protective ventilation. And the ECMO is really only reserved for those a couple of patients that you really can't manage by being more and more conservative with lung protection. And remember in the Eola trial, not all those patients were put on ECMO. They were transferred to ECMO centers, and still 20 or 30% of those patients never went on ECMO because they went to a center that did more with the lung protective ventilation or recruitment or other things before actually putting them on ECMO. So I think that's an important point about that too.
Yeah. So that's very important to understand that, as Dr. Farhan and Dr. Robinda rightly said, it's a very debatable question. And if you're good at ventilating and you know how to ventilate a child with ARDS, you might not require ECMO early, and you could reserve it for certain cases. So there are a couple of questions in the chat box where some of our audience have been asking about the role of steroids and surfactant in ARDS. So if Dr. Robinder could take this, please.
I think we should ask to students.
Yeah. So does anyone want to answer this? Maybe you could put your answer in the chat box or raise your hand.
Yeah, sir. Which one, sir? Exactly.
Role of steroids.
Yeah.
Okay.
Is there a role of steroid or surfactant in ARDS?
Role of steroids, actually, if you see study, it's a double-edged sword in ARDS, but there are few calls which says that steroids actually help. Like, for example, if you see Meduri protocol in ARDS, they have given very nice protocol how to start in the first week and how to titrate steroids over the next 28 days, actually. If we see the Meduri protocol, they have given steroid up to 28 days. But there are, and it's low-dose steroids only. And there is one more study, DEXA ARDS study, and they also mentioned steroids, and they have given dexamethasone. Like Meduri protocol has mentioned about methylprednisolone, but DEXA is dexamethasone. So there are studies which says that there is a role of steroids in ARDS, and both Meduri protocol says low dose steroids, but in DEXA ARDS study they have given very high dose of dexamethasone, and still the results are there. But I think, I don't know, it's still a double-edged sword to consider a role of steroids.
What about viral pneumonia, H1N1 pneumonia and RSV pneumonia? Do you give steroids?
Mainly, steroids in influenza is actually counterproductive. It increases mortality if we see. If we give steroids in influenza ARDS, we have many adult and pediatric studies that it is more counterproductive and it increases mortality. So I don't think it's a good idea to give steroids in viral pneumonias.
Adenovirus pneumonia?
Adenovirus pneumonia is actually, there is a role of steroid, and steroids actually helps in adenovirus pneumonia.
So ultimately, how do you decide whether steroids will work or not? Basically, it's inflammatory. What does the study by Jesus Villar say?
This thing I'm not sure. Sorry.
Okay.
Sir, how do you decide, sir, Ravinder sir, about using steroids? Because basically it's an inflammation at the alveolar capillary membrane. So technically speaking, steroids should work as an anti-inflammatory.
You guys are wading into the challenging questions, right, that have no answers. We have no pediatric randomized trial. And I think for us to try to extrapolate the data from adults to pediatrics, where there are so many potential differences in inflammatory response, mechanisms of injury, comorbidities, is very challenging. We need a well done, well powered international pediatric steroid randomized control trial. And that is something that there's interest to do in the Polizzi network, and we're sort of trying to get protocol started to think about. But I think it would be important for us to do this internationally, because the triggers, as an example, might be a very important source of heterogeneity of treatment effect, and the triggers are very regional and they differ. Ventilator strategies might differ regionally, right? So it would be important, I think, to do this internationally. Even with the viral mediated disease, what about COVID? They're standard as part of recommendations, right, for COVID-19 for steroids, right? And not giving steroids now in COVID-19, we would be looked at as, almost negligence if you don't do that, at least here in the United States, as an example, right? So we have to do a trial, I think, in order to answer this question. And the points that are very challenging for us still with the trial is, what's the dose and the duration? So do we go with, the sort of DEXA ARDS protocol, or do we use some other protocol? It's even more challenging because adult clinical practice guidelines are now recommending steroids, right? The SCCM and ATS guidelines for ARDS are recommending steroids, but we still have zero pediatric data, right? For us large pediatric data to do this. All of the data is from small physiologic studies. So dose is one important problem. And then the second is severity. So do we do this in all ARDS patients? Do we only do this in the severe ARDS patients? Where is that risk benefit profile, in terms of the patients that might be benefited from it versus harmed? So those are all factors that I think have to be sorted out. I can't answer it because I don't know the answer to it. We need a large RCT to figure it out.
Thank you. Thank you both. What about surfactant, Ravinder?
I rarely, if ever, use surfactant. If we look at our the PALIC guidelines, the surfactant trials, right, the calfactant trial in particular, the first calfactant trial had some signal for potential benefit on secondary analysis in the direct lung injury patients, et cetera. But then on subsequent follow-up with the calfactant trial, there didn't seem to be any improvement in outcome, especially in the era of more lung protective ventilation. So it might be that there's an important interplay between surfactant and the use of lung protective ventilation, and that if you are appropriately lung protective with how you're approaching patients, the incremental benefit of surfactant might not actually, there might not be an incremental benefit in surfactant. There's definitely heterogeneity of treatment effect, that there are maybe some patients that benefit from it and some patients that are certainly potentially harmed from surfactant administration. There were a few interesting positive trials that came out of the more developed countries that had potentially high bias, which is why they were not used in the ultimate PALIC recommendations. If you look at the surfactant recommendations that are there, we talk about some of those studies that did show very large improvements in mortality, for example, but there was a very high risk of bias in those trials, which is why ultimately the recommendation was neutral for surfactant, because the quality of the evidence was not high enough.
Thank you. I think that's it. We are done with most of the questions. Yeah, I think that's done. That's all. So I think we'll end here. And I would like to thank all our participants today, Dr. Luisa, Dr. Suchit, Dr. Andrea, Dr. Farhan, and most importantly, Dr. Ravinder Khemani, for sparing time and guiding us through this webinar today. And I would like to thank WFPICCS, my colleague, Dr. Tracy, Lorenzo, and Evelyn from the WFPICCS office. And it was really great to see wonderful cases being presented by Luisa and team and Dr. Farhan from India. And we keep doing these webinars every quarter. So I would urge all the audience to join us again for the upcoming webinars in the next quarter. So thank you all. Thanks for joining tonight. And once again, thank you, Dr. Ravinder, and all the experts. Thank you so much.
And thank you, Dr. Malind, for putting this incredible session together.
Thank you. Thank you all.